Welcome to This Week in Hearing. I'm your host, Bob Trainer, sitting in for David Kemp today with another episode with our honored guest, Dr. Michael Valente. Dr. Valente has been for many, many years a clinical professor of otolaryngology at Washington University in St. Louis, Missouri. He's now a professor emeritus from that institution. Mike, I've learned so much from you over the years and reviewed many of the things and articles and presentations you've done over the years. So it's my pleasure to be the host for this particular session of This Week in Hearing. And my understanding is that you're going to kind of combine the sessions together, do a little review from the first two, and then put things together into looking at the integration of remote fine-tuning and other things we need to do in the practice to continue to be successful in our clinical endeavors. So it's my pleasure and my honor to present my distinguished friend and colleague, Dr. Michael Valente.
Bob, thank you so much for that introduction. It's far longer than I deserve, but thank you so much at any rate for doing that and putting it all together for me. So I wanted to start it off with kind of a general sense of how I feel about all of this. And so I feel that, it's easy to say that audiologists dedicate at least 7 years of their life to college to provide high quality patient care. Some 8, some a little longer, but at a minimum 7. And due to this great care, I can speak for myself. I provided care for over 30 years. Many of our patients do think that audiologists are indispensable. However, I think most would agree that far more believe we are not indispensable just by the low adoption rate that we see around 32%. Because of our, I think, long-held bundled model that create perceived barriers that led to the OTC Hearing Aid Act. We are not as accessible as patients would like due to travel and ease of scheduling. We're not as convenient as patients would like, requiring multiple visits to obtain hearing aids and get into our schedules. We're costly due to the bundled approach that we've taken for decades and really didn't educate patients about the importance of the extensive array of services that we supply along with the product, the hearing aid, as an example, 2cc couplers for quality control, real ear measures, speech and noise validation, and so on and so forth. So we really haven't been able to educate patients on the cost of the device, which is really equivalent to OCT and direct-to-consumer, and the additional cost, which is bundled into that, which is the service that we put in, that can be, depending upon the warranty, anywhere between 1 to 3 years or 4 years. So these perceived barriers of accessibility, convenience, cost, led eventually to where we are now, which is OTC and direct-to-consumer devices, which are more accessible, are more convenient, and are often less costly than what we've been offering over the last several decades. But in spite of all of this, I firmly believe that OTC DC devices present audiology with an incredible opportunity that I dissected and presented in part 2 of this 3-part presentation. But I believe audiologists need to objectively, take the emotion out of it, objectively view the factors that has led to OTC and direct-to-consumer and implement changes within their practice to address these factors to help. I've put together this 3-part series. Part 1, I spent a considerable amount of time to demonstrate very carefully how one could calculate charge per hour to create an unbundled approach to address the issue of cost that led to OTC. In part 2, I discussed how we can integrate OTC type devices into our clinic and use this as an opportunity to educate patients on the value of the services we provide along with the product or the hearing aids. And I spent a considerable amount of time doing that in part two. In that lecture, I provided an example of an entry-level hearing aid using an unbundled approach that we implemented 2 years ago. Today, if I was still directing the program, I would offer several OTC type devices in stock, again, for convenience and accessibility, using the unbundled approach. Again, demonstrating that we are not in a static, but in a dynamic environment, and you have to kind of change as information and experience dictate. Today, I'm going to take the last leg of that three attack prong, and I'm going to discuss how audiologists today really need to think about implementing remote care and remote fine-tuning, which then can address the last two issues, which is accessibility and convenience, that again led to where we are today. Not to belabor the point, but if you go back to where we are, there were a series of meetings in 2015, 16, and 17 to kind of set the stage as to why OTCs need to be made available. And if you read them, you'll notice that they kept honing in on some three key points. We need for consumers greater accessibility. We need for them to have greater convenience. They have to cost less, because they felt that these three factors were causing the 70% of hearing impaired patients not getting hearing aids. Cost was another one in 2016. In 2017, access, convenience, affordability. All of these things led to the OTC Hearing Act for mild to moderate hearing loss in 2017 that finally is coming in October of 2022. So here we are, and let's go through some of this. So just so that we're all together on this one, this presentation is not how to do remote care and remote fine-tuning. That's a much, much longer presentation, but rather why you should do it and how this could be integrated into a clinical practice, and share with you how this was done here in St. Louis. So before we get to that, I want to kind of define for you, in my world, what is remote care and how is that different from remote fine-tuning. Remote care resolves problems remote, kind of like a secure Zoom. It doesn't require manufacturer software, nor does it require a clinic visit. This addresses the issue of accessibility and convenience. Audiologists, this is not new, audiologists have been engaging in some form of remote care for decades by either telephone or email communication with their patients. But Zoom adds the additional dimension of seeing the patient and the hearing aids at the same time, and this can significantly improve your ability to resolve problems without the need of an office visit. Remote fine-tuning, on the other hand, also resolves problems remotely, but it requires a smartphone using a strong Wi-Fi and a smartphone with unlimited data plan, and it doesn't require an office visit like remote care. This, however, utilizes a manufacturer software to reprogram the hearing aids, as well as provide additional services provided within that software, and it varies quite significantly across the different manufacturers, and I'll share some of that with you later on. This also addresses accessibility and convenience. So these are examples in my head when I put this together, what would constitute remote care. So the way I thought about it was, when I was providing clinic care, oftentimes I would say to myself, really, does this patient need to be here for me to resolve this problem? I could have done this by a phone. I could have done it by Zoom. So requiring an office visit addresses the issue of convenience and accessibility, which is part of what developed the OTC law. So by having a Zoom, you could, I think, significantly reduce the number of visits that a person would have to schedule to see you that could have been resolved simply by face-to-face communication. And here you see just a litany of potential issues that I thought about when I was doing clinical service that I could have solved in my office with the patient on their phone or their PC. And by seeing them and the ear mole and the hearing aid, we could have resolved a lot of these problems and prevent the patient from having to come into the clinic. And then also, oftentimes, I'm sure, and we'll talk about that in a little bit, you'll soon learn that there are things that you thought you could resolve by Zoom, but you can't. And during that Zoom, you apologize that you can't resolve that problem, and advise them to mail the device to your office or schedule an appointment if the remote care doesn't resolve the problem. And I have an example of that in a slide or two down the road. You can resolve feedback by correct insertion of a dome or a mold, or perhaps counsel the possibility that the feedback is being caused by cerumen. And again, if you can't solve the problem by counseling the patient on reinserting the ear mold because it's not inserted correctly, how many times have you seen a patient with feedback? They come in and the ear molds are on the wrong ear. You could have resolved that problem with a Zoom, or it's in backwards, or it's not in all the way. I mean, there's a lot of things that can cause feedback that you can resolve face to face. And if you can't, if all these strategies don't resolve the problem, you can advise the patient, we tried, it didn't work, and now we need to have you come in and we can resolve the problem. So I think it's important, and this is what I would do, to counsel patients in advance that it is possible that a remote session may not solve the problem. And as you gain more and more experience with this, you'll begin to create a library of experience that in advance, the Zoom will take care of this. Or this has presented some challenges in the past, or this is not going to work. So here's an example. A patient calls me and says, Mike, my aids are dead. And then I say, well, why don't we schedule a Zoom and we see what the problem is. How many times have you had a patient with a RIC that's dead, and before the patient has sit down in the chair, it's a wax trap that is clogged with wax, and you could have solved that in 10 minutes, but to make up the time, as you should, you clean the hearing aid, you test them in a 2cc coupler, but the wax trap, the wax in the wax trap is probably the biggest cause of a patient saying this aid is dead. That could have been solved by Zoom as opposed to having the patient come in. And in our clinic, when we gave a patient, we dispensed a behind the ear hearing aid, we gave them an air blower. So by seeing the tubing, by utilizing that person's camera, I could see if there is moisture in the tubing, and I can explain to them, show them how to use the air blower to get that out of that tubing. We give our patients dehumidifiers as part of our dispensing practice. Have they been using the dehumidifier? Does this solve the problem? It could be, as you know, a dead battery. Is it the correct battery? How many times I had a patient where it was a 312 and they tried to get a 13 or vice versa? They had the wrong battery in there. Is it inserted correctly? How many times have you taken a dental pick to get a battery out of a battery compartment because it was inserted incorrectly? Corrosion of the battery or the contacts. A lot of this could have been resolved by Zoom. Is there obstruction in the tubing? Is there a crack in the tubing? Obviously, I can't change the tubing, but I can say the problem is a crack in the tubing. You've got to come in so I can change your tubing. Or if it's a broken receiver or some other component, I would tell the patient, well, I can't fix this by the Zoom, and this is why. Why don't you come in, and we will take care of it. And again, it completes the circle. And then you also must know that there are some remote finding software from manufacturers that can actually test a hearing aid and it at home, and it can depict whether or not the problem is in the microphone, the receiver, or external excessive internal noise. And that's a technology you might want to think about taking advantage of. And almost all of these manufacturer softwares can also do a feedback test. So there's a lot of things you can do remotely, again, with the goal, accessibility and convenience. That really is the goal. So these are just a small sample of parameters that can be resolved by remote fine tuning, and they are manufacturer specific. This is not the complete list. I just simply popped out in my head the ones that I remembered the most common from the 4 manufacturers that we use. And several of these could be provided by a hearing instrument specialist if you should hire such a person within your practice, or by an audiology assistant. And we'll talk about that later on in terms of how do you fit this into your schedule. That's later on in the presentation. So you can do full programming capacity, like being in the booth connected to the computer, directionality, time constraints, wind noise expansion, noise reduction, gain adjustments, program changes, phone streaming settings that I think a audiology assistant might be able to do, accessory streaming settings that, again, I think an audiology assistant can do, acceptance manager, in situ measures. This is an interesting one to me that I wish I would have still working, and I would work on this one. I'll just give you an example. In our clinic, when we were dispensing hearing aids, we did the audiometric test through the hearing aid and coupled to the person's ear. And the one that comes to my mind is the sensogram from Widex. And you have that in that patient's chart. Wouldn't it be kind of nice as a screening tool, you reassess the hearing utilizing the remote fine-tuning software and see if there is a significant change or not, and whether or not that person should be visited for a full comprehensive audiogram, or tell the person, hey, you know what? Your hearing hasn't changed just the last time, and you can do that remotely. You can do a feedback test remotely. You can assess the functionality of the microphone, the receiver, and internal noise. That can be done by an audiology assistant, or hiring a hearing instrument specialist as part of your team. There are a lot of different ways in which you can address this. So, a couple of words about remote fine tuning, and we'll get into this in greater depth later on. There are 2 different modes of remote fine tuning utilizing manufacturer software. One is synchronous. That means when you make the change, it's made to the patient in real time. And in our clinic, we did this with Widex, Phonax, Starkey, and live assistants on the Resound. Another form, which is not as widely used or as popular, is the changes are made, and at some point later on down the road, the patient downloads it to the hearing aid and it's stored in the cloud. Resound offered this early on. This particular method is problematic because the patient may be in a locality other than the locality where I, as an audiologist, is licensed. And that presents a quagmire, which I'll talk about later on in the presentation. I can't tell a patient, for me to do this, I need to be sure you're in St. Louis or Missouri, and therefore the Arch or Busch Stadium has to be behind you. Or if I see his or her on my monitor, and I notice that there's palm trees in the background, or there's a mountain in the background, or there's an ocean in the background, clearly that person is not in Missouri, and I would have to tell the patient, I'm sorry, you're not in Missouri. I can't do this. And I'll touch on that in a little bit. So this particular method of remote fine-tuning was clearly defined by the medical school. You cannot do this as you get into remote fine-tuning or remote care. But there is help coming around the bend, and I'll share that with you later on in the presentation. So I think one good starting point on all of this, and it also addresses another problem later on down the road, is how popular is telemedicine? That became really popular during the pandemic because all the clinics shut down, and we had to find, not we, but the medical school and all healthcare professionals had to find a way to maintain relations with patients, as maintaining relations and also as a form of revenue generation. So this is from the Government Accountability Office. And what they found was during the initial phase of the pandemic, which would be March 2020, Medicare had 325,000 telemedicine encounters. In mid-March, which was the beginning of the pandemic, it shot up to 1.9 million. And then as the clinics began to open, it decreased to 1.3 million by June 2020. But still, 1.3 million is a big number compared to 325,000. They also reported that more beneficiaries who were less than 25 used it more than those who were greater than 65. I mean, less than 65 and more than 65. More urban beneficiaries, people living in cities, used telemedicine than rural beneficiaries. And similar proportions of beneficiaries used TM across all racial and ethnic groups. I only mention this because of the popularity, and that'll come on later on as to addressing one of the reasons why audiologists as a whole don't seem to be embracing remote care and remote fine tuning. So my entrance into this began in the pandemic, where telemedicine became crucial to maintain relations with patients and generate income. But the medical school, and like almost everybody else, was totally unprepared. As a footnote, I actually approached the medical school in 2019 to discuss audiology, providing remote care and remote fine tuning. This is before the pandemic, but the medical school simply would not allow audiology to do that because they were concerned about provision of care with a patient in a locality other than the state where we had licensure, which was Missouri. So they just shut it down. So due to the closing of all clinics, and we closed everything, ENT, audiology. I mean, we just shut it down like everybody did around the country. And medical school was forced to rethink this. And in a really rapid time frame, they implemented telemedicine. And of course, audiology became part of that. We were finally allowed to do it, but we prohibited again from offering to patients who were not physically in Missouri unless we obtained a license in that other state. So we could not use asynchronous fine tuning, which at that point was resound. So to prepare for this presentation with Bob, I contacted our manufacturer reps, which again, no particular reason, Widex, Phonak, Resound, and Starkey, and I wanted to find out from them how popular was remote fine tuning with their accounts. All four reported that remote fine tuning was not being used, less than 10%, as predicted, given what they felt was a tool to improve patient care, accessibility, and convenience. They thought that this tool would improve patient satisfaction, increase the number of appointments, and increase revenue. But in spite of all of that, less than 10% of their accounts, and in many of them, less than 5%, simply were not doing it. And so I asked them, which doesn't take a genius to figure this one out, why? Why would you think this was the reason? And they gave me the following answers, and it was by either their hunch or direct communication with the staff of their accounts, which is quite large. What they came out with, and this was consistent across the four manufacturers, there was a hesitancy to adopt and learn new technology. Okay, and I'm going to expand on that lower on in this slide. The staff, hesitant to counsel on its availability and the advantages that this might provide. They lacked how to integrate this into their practice, because this is something that's entirely different. and I'll expand on that later on. They lacked any knowledge of how do you charge for this, or do you charge for this? They were concerned, can we do this within our scope of practice and abide by all state and federal laws? The most important one out of all of it was this feeling that if we did remote care, the patients were never going to come back to the clinic and see us, and we've lost them. They were also expressed, not uniformly, but quite a bit, that they didn't think that patients could handle this technology or have access to this technology. And then I just want to put the last point down here because it'll kind of dovetail to something I have to say later on. We, as a presenter, we have to understand that the software for remote fine-tuning for some manufacturers can be initially overwhelming. And I'll share that with you a little bit down the road. And the other thing we have to bear in mind, unlike manufacturers of direct-to-consumer devices, where the staff have to learn one fine-tuning software package, in our clinic, we had to learn 4. And that's quite a bit of information for staff who are doing other things in addition to hearing aid care. And so we have to kind of bear in mind that we're asking a single audiologist who's part of the dispensing practice to learn several software packages. And again, some of these are, and I'll show you later on, they're quite extensive, require a lot of steps. And to do it on one, but to do it on 4 is quite the task. And again, you have to bear in mind, and I will later on, when you have an example, Lively, which is direct to consumer, those audiologists only need to know and operate one fine-tuning software package, whereas audiologists have to do as many manufacturers that they use that they dispense. Just bear that in mind. So what I'm going to do now is I'm going to address 4 of the concerns that audiologists have expressed why they've not adapted remote fine-tuning. But before that, I just want to share with you, this is an article that was, and the next slide you'll see it, was just published in AJA on their website by Doctors Harvey Abrams and Christina Callahan in AGA, the American Journal of Audiology, that literally addresses some of the behavioral reasons why audiologists are reluctant to provide telemedicine. And then they offer several strategies on how to overcome and change that behavior. I was emailing back and forth with Harvey, and he introduced me to this article, and I read it over the weekend. And I would urge, people who are interested in this topic to go to the AGA website, pop up that article and read it. It's quite interesting. And there's the article. Just came out literally last week. Health behavior and motivational engagement models can explain and modify teleaudiology uptake. And then Harvey also introduced me to another area that I was simply not aware of, and I'm going to share that with you in a little bit. And let me kind of give you a reason why I contacted Harvey. Number one, he and I have been friends for quite some time, and I always, there's something that just befuddles me, I'll contact him. So I asked him, Harvey, this was an email, it wasn't communication. How is it? And I think I knew the answer, but I wanted to get the answer. How can audiologists at Lively provide remote care and remote fine-tuning to their customers who come from all 50 states and God knows where else? How do you overcome this statewide, you have to have a license in your own state, quagmire? And he provided me the answer, and that's exactly what I thought the answer was going to be. But he also introduced me to something really special that I'm going to share with you in a few moments. And I wanted to give him credit for that, and I'll share with you in a little bit. So what I'm going to do now for the next several slides is I'm going to go out on the limb. This is Mike Valente talking. And I'm going to go over what seem to be the 4 reasons audiologists are not embracing remote care and remote fine-tuning, and provide a counterpoint, an opposite argument, or some kind of reasonable argument to that. So here we go. So if anybody is going to get mad at this, at the end, you'll see my email address and you can contact me. I have really thick skin and I can take it, I think. So the first one is fear of losing patients. That if a patient does remote care or remote fine tuning, they're going to be so happy because of the accessibility and the convenience, they're not going to come in. So I said, limiting access and convenience by requiring numerous office visits is why we are where we are. Audiologists, however, fear losing patients using remote care and remote fine-tuning were offered in spite of implementing accessibility and convenience. They actually believe that if the patient tastes that Kool-Aid, they're not going to come back. So my argument to that is, if this concern is legitimate, why are so many healthcare professionals scheduling remote care and don't think their patients won't return to the office? When we started remote care at the university, every faculty and nurse practitioners were also doing the same to their patients. And I would talk to them about this issue. And I didn't know this was an issue. And none of them expressed a concern that somehow this would turn off the faucet and these patients are not going to come back again. This is the really big one. This is the next one. Remote care and remote fine-tuning is used as a marketing tool by many direct-to-consumer and OTC manufacturers as a way to attract consumers to purchase their products and abandon the brick-and-mortar clinics because this addresses accessibility and convenience. The people that you're most concerned about negatively impacting your practice are doing this, and you need to think about that. Finally, this concern, and this is, where was this concern during the pandemic when you utilized telemedicine? There didn't seem to be an expression or a concern that the patient's not going to come back. And then as the clinics kind of opened up, the number of people using remote care decreased. Harvey beautifully explains this in his article. So if that was a concern, why was it not a concern during the pandemic? And after the pandemic, at least my experience was, these patients came back to audiology. So I think the fear of losing patients by implementing this is questionable at best. So the next 7 slides, what I did is I took screenshots from 7 different manufacturers and hearing healthcare providers on their website. Remote care and remote fine-tuning as part of their package to induce them to come into their link, their website. So half of our customers use the video interface on our app, while the other half prefer by phone. And this is MD Hearing that I got from their website in August 2022. So it doesn't seem to bother them to do remote care and remote fine-tuning. Here's Lively. Professional follow-up care included for 3 years. Remote follow-up care along with easy adjustments through our app, far more convenient and affordable than repeated office visits. This is your competition. This is Lexi Lumen, your professional Lexi expert in the comfort of your home, available by video or by phone. Remote adjustments to your hearing aids. Experts are able to make remote adjustments. Your competition is promoting something that you have access to right now, and 90% of you or more are not doing it. Here's UHC. This is a healthcare provider through their new program called Right to You, remote access hearing healthcare to members of United Healthcare who have this particular policy, helping expand access, reduce the need for in-person appointments for fittings and adjustments. The capability known as RU2 builds on home-delivered hearing healthcare developed by United Healthcare, adding the virtual care component that is designed to help reduce the need for in-person appointments. There's a healthcare insurance that are doing it. Here's Atticus, unlimited telehealth support from audiologists. Here's Eargo, remote care provided by hearing instrument specialists or audiologists. Lifetime professional support. GN Jabra, Enhanced Pro. Again, remote care, video appointments, and remote fine tuning. So I couldn't find a more powerful tool to urge you to think about this than the competition that was created by the fact that we did not do this for decades. And we have the capacity to do it now. But yet, 90 to 95%, I'm told, do not integrate this kind of technology into the hearing healthcare. So another one is fear of violating scope of practice as well as state and or federal laws by doing this. This is a legitimate concern, but by the click on a website, which I'll share with you in a moment, you can resolve whether or not this is a problem. You can go to AAA website. You can go to the ASHA website. When we did it, we went to the Missouri Licensing Board for advice on by implementing remote care and remote fine tuning. They did not get back to us. This was at the height of the pandemic. So to circumvent this obstacle, I sought the advice of General Counsel, which is an office within the university that deals with anything that it remotely relates to legality, and put forth the proposal, and they advise us what we can do and what we couldn't do. But as an aside, because we live in a very litigious society, I routinely sought legal advice before implementing anything, this is over 3 decades, that I felt needed to be resolved before moving forward. So it's always a good thing to check, double check, triple check before you say, okay, I'm good to go. There are no problems here that I can be in violation of any federal, state, or equally as important, third-party contract for hearing aids. So this is the top 2. Those are links to ASHA on tracking state laws and regulations for telepractice and licensure, and then payment and coverage considerations for telepractice during the COVID pandemic. The one below is the AAA website to get to this page, which is telehealth and licensure. So there's a lot of sources out there that can answer your questions to resolve that fear of somehow by entering into remote care or remote fine tuning, you might be in violation of scope of practice or federal or state law. This is something I was absolutely unaware of. And this is something that Harvey tuned me into. And there is an organization that is known as SLEP, I guess, IC, which is Audiology and Speech Pathology Interstate Compact. And it can be accessed through the ASHA website that you see on the top line, or you can go directly to the website, which you see on the line below it. So I'm going to show you some screenshots from the actual website and kind of share this with you. This is important. So here is the ASHA website on the Audiology and Speech and Language Pathology Interstate Compact. And there is a short video, and I mean short by 2 minutes, that you click on, and it tells you what this is all about, as does the verbiage inside this website. And then I clicked on the actual website, and this pops up. And then I'm going to show you in a little bit on the bottom on the menu, there's a thing called Compact Map, which I'm going to share with you in a few moments. What this is a national effort so that I, in Missouri, am licensed as an audiologist. I can provide service to my patient who happens to be in Arizona, Florida, California, Maine, and I no longer have to worry about, does the patient have the arch behind their back when I see them on the monitor? And I don't get concerned if I see a mountain, palm trees, or an ocean. And when you go to the compact map, as of today, there are currently 23 states that have joined this compact. Illinois and New York are pending. And the ones in gray, again, as of this morning, have not. And if you go through and you read the website, their goal is for this to be in place in 2023, next year. So it is entirely possible a year from now, you don't have to worry about where does that patient reside when you're providing this service. And one other thing, I'm in Missouri, so I went to this map and I clicked on Missouri, and it showed me, and I can click on that, the 3 bills in Missouri that support this. And every one of those states that in blue, you can do the same thing. So this was introduced to me by Harvey, and I'm indebted to him. And I learned, I didn't even know this was available, and I thought I would just share it with you on the assumption you don't know that it's available. And I think this is very, very exciting. So here's another one. Number 3, patients can't handle remote care or remote fine-tuning. So this is my blurb on this one. During the pandemic, Zoom encounters with friends and family were very common. I personally, every month on a Sunday, get together with 3 high school friends, of which 2 live in Florida and 1 lives in Cape Cod. I get together weekly, my wife and I, Maureen, with our daughter, son-in-law, and grandson who live in upstate New York. So this fear of patients not handling remote care is, are you kidding me? Everybody and his mother, it seems, has been using Zoom for the last 2 years in some form. FaceTime, as an example, on iPhones is a form of Zoom. This presentation is by Zoom. Yes, there will be patients who do not want to use this technology or unable to use this technology. But as reported earlier, audiologists or hearing instrument specialists of 7 manufacturers of direct-to-consumer products provide this service. Surely, this is when we get in trouble, surely the audiologist and hearing instrument specialists providing remote care and remote fine-tuning and their patients using these services can't be different or smarter from the patients you see in your clinic on every day. I mean, there isn't this pod of patients in Missouri that can't do this when the rest of the nation can. So this idea that patients can't handle this, I think, is more of an assumption than a fact. Also, the patients of other healthcare professionals routinely use remote care. Almost all of the ENT staff utilize remote care. My own personal physician and my dentist, of all things, offer this option when we schedule appointments. They think I can do it. And you know what? I can. And I take advantage of it. And then going back earlier in the presentation, data from the Government Accountability Office cited earlier, 1.3 million Medicare recipients use it. So why would we think that audiology patients can't do this? And then here's the one that I really gave a lot of thought to, and I don't really have what I would consider the definitive answer, but I'm just throwing stuff against the wall and see what sticks. But it's based upon a premise. If the goal is to address accessibility and convenience, doing it spot meal within a clinical schedule is really not solving the problem. In other words, when we had a patient coming in for what we called the hearing aid check, it was embedded in my schedule. That was before an audiogram, after an audiogram, another hearing aid fit, whatever it might be. But that was the pod. And if I'm going to get into remote care and remote fine tuning, I got to think of those 7 or more manufacturers that say, you don't have to wait for 2:00 in the afternoon on a Tuesday or 4:00 in the afternoon on a Monday, because that's where my opening is. We're open 5 days a week from 8:00 in the morning to 4:00 in the afternoon. You pick the time and we'll send you the link and we're good to go. That's where I think audiology needs to go. So what I did is I asked 5 colleagues in private practice in it was actually 5 different states. 2 were from the South and 3 were from the Midwest. Number one, do you do remote care? And do you do remote fine tuning? Because, it's less than 10%. So I think the answer to all 5 would have been no. And if you do, how do you do it? Well, as you might imagine, with 5 practices, there was a lot of difference. But 3 out of the 5 use audiology assistants to do it. And I never really got into, is this a spot thing or is it offered, my vision full time? So I'm just throwing out the possibility in these next several slides of things you might want to think about and how you might want to handle this if you decide to get into this arena. So my first thought to you is you got to think out of the box, because what we're doing obviously didn't work, or else we wouldn't be in the quagmire that we're in terms of accessibility and convenience. And what you do is what I did. You collaborate with colleagues, with and outside of your organization, on how this service is provided. There are really 2 good Facebook groups that I'm a member of that is really, really helpful. One is called Audiology Antics and Anecdotes for all hearing professionals. And the other one is Audiology Best Practice. And there are hundreds of things thrown out and hundreds of comments that are provided to the person who asked the question. One question you might want to ask, as an example, if you were part of these 2 groups, how do you handle remote care? How do you handle remote fine tuning? Who does remote care? Who does remote fine tuning? Do you offer it full time? Do you spot? How do you do it? And it was through those kinds of interactions that my thought has changed. And I'll show you a slide later on, but I'm getting ahead of myself. The way I would do it today with the information that I have in hand is not the way we did it 2 years ago when we started this, because technology has changed. A lot has changed, and you've got to be able to kind of go with the flow. So these are potential thoughts for you to do this. I don't think substituting an in-office visit, what we still do, a hearing aid care, is the answer. This spot on, because that doesn't get to convenience. You need to think about having one audiologist or more than one schedule an entire day, where that day That's the way my physicians do it, where the day is just remote care appointments. My physician sets aside Friday to do remote care. Or you can do a morning or an afternoon. The point being, you set aside a block and not this sporadic thing. When you do it physically, it's exactly the same as you would be if you were in the clinic room with the patient, but only now you're in your office. And you're not utilizing, you're freeing a clinic space. It's not any different. And I'm going to talk about charge about this later on in the presentation. The last one here, think about this. Let's assume you decide not to charge, and we know audiologists are marvelous in not charging, as I said in one of my 2 other presentations. Or I sometimes think audiologists are as close to social workers as you can be without getting a degree in social work, an MSW. But that's a whole different thing. But let's assume you did that, okay? Because the person that you're seeing is in the bundled approach, and we provided this care as part of the warranty. Just by the mere fact that you offer it, and by the way, and you'll see later on, offering it is not the answer. It's only part of the answer. You have to offer it and you have to promote it. You just can't say, well, to this patient who calls you, hey, we can do this. This should be part of your routine when you counsel patients on why they should want to go to Washington University as opposed to so-and-so down the road or so-and-so in this state. Because, if the data is correct, there are many people around you doing this, and this is going to set you aside. You're going to be separate from your competition by just doing it. And you don't have to get into remote fine-tuning. We can get that later on because it's more complex. Just a Zoom with your patients, set aside a morning, an afternoon, or a whole day. Dip your toes in the water and start simple. Promote remote care via Zoom to the patient's laptop, computer, smartphone. I do Zoom, as I said, with my friends once a month. And if, one of the concerns audiologists have is, oh my God, this thing is set for 30 minutes and this person is going to talk over. And then I got a problem here. For those of you who use Zoom, it shuts down. I mean, it just shuts down. And you can set it for 30 minutes and you can set it for 40 minutes. And there's a timer. And you can tell the patient, we have 3 more minutes to say what we got to say. And then you're not going to see me anymore. So you can resolve that endless conversation by Zoom. You can inform patients if there's a charge or not. As an example, it could be no charge if these charges were no charge as part of your bundled model, or you might consider hiring a full-time hearing instrument specialist or an audiology assistant to offer this service full-time to truly address the issue of accessibility and convenience. Now, I know if I hired an audiology assistant or a hearing instrument specialist, this was their thing. I know early on that the amount of time they're actually going to be doing this is relatively small. But the hope is in time, it's going to grow, it's going to grow, it's going to grow, and it's going to grow. And they have a multitude of other tasks that they can do to fill in that quote unquote dead spot. And then the goal is 3 months, 6 months, 9 months, whatever it might be, the number of people, because it's being promoted, who take advantage of the service will grow and grow and grow. And that's what you want. You want this to be, you want to address what it is that got you in the problem in the first place, which is accessibility and convenience, and also being used by the people who's your competitor. And doing this spot meal is just not going to do it. And showing you what I did in part 1 of this presentation, you charge for that service for 30-minute increments if you're using an unbundled model, which I explained in the first and in the second presentation. You can use this time, whoever this person or persons might be, to learn the in, the outs of the manufacturer remote fine tuning, and then over time, kind of like overlap, over time as the comfort level gets better, you can expand into that service. You're just trying to, as it says in the top of the slide, dip your toes in the water and work your way up. I think clinics should start offering remote care as soon as possible and add remote fine tuning later on as the bugs specific to your practice are worked out. Another possibility, you might have an audiologist who really likes this, and that person would be the person doing this. So I'm just throwing ideas out and to have the listeners kind of think about ways in to address this issue of how do you schedule this. So again, it's got to be full-time in my mind. And again, you want to verify state licensure for what a hearing instrument specialist and or an audiologist can or cannot do. And I'll show you a website about that in a few moments. So what I did here, I took my Excel spreadsheet from number one and I created an artificial budget. What would it cost my practice if I added an audiology assistant? Now, mind you, I have no idea what a salary is for an audiology assistant, but it doesn't make a difference. You can pop this stuff into the Excel spreadsheet and it'll calculate whatever you put in there. For my example, I assumed that I would offer this person $45,000. I just threw that out. And then I assumed an additional $11,000 for fringes and other things, which took the cost to $76,000. For the purposes of what we're going to talk about, it really doesn't make a difference. I put this increased cost into my Excel spreadsheet that I talked about in part one, and it increased that row to $2,156,344. And I added the number of staff from 9 to 10. So you got to go back to number one in order to get the gigs of all of this stuff. The spreadsheet recalculated in a millisecond the increased cost, the change in the cost per hour as a result of hiring this person. So my cost per hour was actually reduced from $195 to $180. I added somebody. Why? Because of the increased number of billable available hours. So my number of availability was from 18,720 to 20,800. Remember, part of the formula of cost per hour is your cost minus your cost for devices divided by billable hours. And that's included in the spreadsheet. So what it told me when I inputted this was that it decreased my charge per hour from $235 to $216. And that would give me comfort to suggest that their services could be offered at no charge, and it wouldn't affect the profit of my division, but it would increase my convenience and accessibility. I'm not suggesting no charge. I'm simply suggesting it's conceivable, and it would require a lot of work. Not a lot, some work. So if you're interested in an audiology assistant, this is the website, and you click on the state, and it will tell you the law in that state on what an audiology assistant can or cannot do, what they can bill, and what they can't bill for. It's a wonderful website. So how did we do it? And again, keep in mind that this service will be revised as experience and information changes. Like I mentioned early on, I already would have changed from what I did 2 years ago based upon what I've learned in the last 2 years. Also, keep in mind that remote fine-tuning was adopted in our clinic 2 years ago. And there's a number of changes I would make to that based upon what I know now that I didn't know then. Also, on some of the manufacturers, Starkey is an example that I know, really fine-tune their remote fine-tuning, and it doesn't have nearly as many steps as it did 2 years ago. And so the software in your booth that allows remote fine-tuning with your patient has also changed, and that would be incorporated into how you implement this in your practice. So, like anything that I did in the 34 years when I was in, I just didn't jump into it. I never adopted something because it was the thing. I would get together with staff and say, okay, we've been approached about this. What do you think about it? And examples that came to mind was ear lens that I really wanted to do, but the otology staff didn't come on board. Lyric, we did. 3D scanning by Lantos, they came to me. Incredible technology. They did scans of my ears and made for me the best ear molds I've ever had in my entire life. But at that time, I said no because it was so cumbersome and so expensive to do that it didn't make any sense to get into it. That would change now because their model has changed and I would revisit it. We implemented stacked ABRs because one of the audiologists wanted to introduce, that was a bust. But I wanted to do it because one of the audiologists wanted to do it. We took time out for her to train. We bought the equipment, so on and so forth. That was one that didn't work out so well, and we just bit the dust on that one. I had 2 audiologists that wanted to do tinnitus retraining and misophonia therapy, got into that, did very well with that. The point is, before we got into anything, remote care, remote fine-tuning, we did a lot of work up front before we said, yep, it's a go. No, this is not going to work out. So I'm saying, just because I'm saying to do this, you really need to research, can your clinic do or not do this, and not just do it because it's the thing to do. Then we looked at, when we decided, yeah, this remote care, this remote fine-tuning, this makes sense. We had to go back and look at the resources to do it. Did we have the staff? Was it profitable? Did we have the equipment? How do we schedule this thing? How do we bill and collect for this thing? And then if we didn't have it, what did it take to get it and what is the cost? And then create a proposal, put it into my spreadsheet, and then we'll calculate quickly the impact on profit and loss and use that as one tool to determine whether or not we wanted to do this. Is it profitable? Or should it be charged? And if we do charge, how do we charge for it? Does it improve patient care? And finally, seek legal advice to be certain that the service and adheres to all policy, procedures of the institution, as well as state and federal laws and third-party contracts. I don't want to be the one. Not my biggest fear, but one of my biggest fears as the director at the medical school was me getting a phone call or an email from the dean asking me to come visit him. That gave me cold sweats at night because I did something that I shouldn't have done. And fortunately, in the 35 years, I never got that email. I never got that phone call. That doesn't mean I was a good director. I just was under the radar. So when remote care and remote fine-tuning was finally approved by the medical school, again, we could not use asynchronous fine-tuning. And here's the problem. Then and now, that red circle is St. Louis. All of our staff have licenses as audiologists in the state of Missouri. But we live right on the Mississippi, which means we have a lot of patients from Illinois. We could not offer at all remote care and remote fine-tuning to a large bulk of our patients because they physically resided in a state where we did not have a license. Now, of course, we could have gotten a license in Illinois, but we elected not to do that. But during the course of a year, remember, this is an elderly population. They'd head off. Oh, no, that's Illinois. We had a lot of patients went to Arizona. We had a lot of patients that went to Florida. We even had one patient that went to Maine. And we told these patients, if you're in Arizona, if you're in Florida, if you're in Maine, have a great time. But as far as remote care and remote fine tuning is available to you, can't do it. Now, again, hopefully in 2023, this problem will be resolved, but this is where it stands right now as far as I'm concerned. So, what steps did we take? We recognized that many of the resources were already in place, didn't have to do much. We recognized the importance of offering a new service, competing with direct-to-consumer, addressing the issue of accessibility and convenience, and being current and competitive with other clinics in the region. We identified other factors that would need to be addressed in order to implement. We addressed each factor so we could go forward. As an example, and I have a slide of this later on, all of our fitting computers were desktop. So we had to go out and invest in a microphone and a camera to put on the monitor to do this. Minimal cost, but we had to do that to make this work. None of our software were on laptops. If I were to hire another audiologist whose exclusive purpose was this, I would purchase a laptop, and that would be set aside for that person so that all the other computers that are required for hearing aid fitting are free, and you don't run into this issue of double use of a scheduling problem. Here's another one because of the institution I was in. Will this technology advance the education of the interns and the externs that we had every semester? Obviously, the answer is yes. How much time is required? 30 minutes. And we communicated this with our department schedulers and our clinic schedulers. How do we bill? And we communicate that with billing and collection. It's all self-pay. It had to be approved by general counsel to be sure that what we were doing was in compliance with all regulations. Did we protect patient privacy and security? HIPAA. How much time is going to be required to train the staff? And I'll briefly touch on that later on. We had to develop new materials to promote this and counsel patients on the advantage and the disadvantage of this technology and what we would charge or not charge. And we had to develop detailed cookbook guides for each of the manufacturers to give to the patient, to give to the audiologist, so that when they had a patient with so-and-so, they could do a quick, oh, this is what I got to do, step, 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 step. And it literally was step, click, step, click, step. It was literally step by step with screenshots. And this was handled by one staff audiologist and one extern. They did a superb job in putting all of this together. And I'll share a little bit of that later on. So other considerations on charging for remote charge and remote fine tuning. Know your state licensure law. For example, I didn't know this, but I was told by an audiologist in California that if our policy is that these visits are no charge in the clinic, we can't charge this if we offer it remotely. Again, always seek legal advice before you move forward on anything. If you're using a bundled approach and the policy is not to charge for office visits during the warranty, I think it's reasonable that it should be provided at no charge, because that's what you would do in the clinic. You could consider, which we did, offering it as an added value, which I'll talk about in a few minutes, to be charged either by a per visit or by a subscription, which I'll share with you in a little bit. Again, obtain legal advice on all of this before you move forward. If you're using an unbundled approach, which I talked about in part 1 and part 2, absolutely. This is an item from the menu that you would charge for in 30-minute increments. And I explained, how to go about, calculating that. So if you're going to charge an unbundled, going back to lecture number 1, know your cost per hour, converted to charge per hour in 30-minute increments, and this should be included in your menu of services. Now, I thought about this because it was actually given to me by somebody else. You provide a service, but you charge for it that you might not ordinarily charge for it because it's an added value for convenience. And I thought about that. I don't do this, but I have a lot of friends when they go to a restaurant, they do valet parking. Believe me, it's going to cost you more to do valet parking than if you took the time to park your own car because of the convenience. Maureen and I, we're big St. Louis Cardinal fans. And we live 3.5 miles from Busch Stadium. I know you're going to think this is nuts. And if Maureen was here, she would back me up on this one. But I'm so frugal that we walk to Busch Stadium to buy our tickets at the window rather than spend the $20 or $30 per ticket online. Again, you're paying that money because you're clicking on a website to order the tickets, and you can download it to your phone. You're seeing the same game, but you're paying for it, the convenience. How many people during the pandemic used Instacart? We did. And you know that your bill using Instacart is not the same than if you went to the supermarket and bought your own food. Food delivery. Yeah, you order pizza, they deliver it to you. I assume you give them a tip. It's going to cost you more. Now, here's something else to think about, and I don't have it in my slides, and I thought about it this morning, and I should have put it down, but I didn't. I'm going to give you 2 examples of this. Let's say you have a remote care, and it's to solve a problem that the hearing aid is dead, but you find out you can't do it for the reasons I showed before. I would bet you that there is an audiologist or somebody listening to this presentation, the one person who decides to listen to this one, who will say, well, you couldn't solve the problem, therefore you shouldn't charge for it. And I would say, nonsense. I'll give you 2 examples. We have a security light in the back by our garage that went out. I'm not an electrician. There are 2 things I hate fixing around the house. One is electricity and one is plumbing. So I called an electrician to come in to fix it. He couldn't. Do you think he went back in his truck and didn't charge me for the visit? I got a bill, and I should get a bill, and I paid the bill. So I'm saying, if you're an audiologist and you're offering the service and you can't fix it, don't default to no charge. You don't do it as a consumer. Another example, we had a leak down in the basement, and for the life of me, I couldn't figure it out. A plumber came. And by the way, electricians and plumbers are not cheap. The plumber came, spent 45 minutes here, couldn't figure out what was causing the leak, so the water kept dripping. Did he not charge me for his time? He did, and I expected him to. So the point I'm trying to make here is, if you have a remote session, and it's an unbundled and you charge for it, you do it, but it doesn't solve the problem. The patient has to come in or whatever it might be. That's not a no charge. That's a charge. So we created a patient information packet geared towards convenience and accessibility. And part of the package outlines what that means. You minimize your exposure to infectious disease. You don't have to travel. You don't have to deal with traffic. You don't have to pay for parking. You don't need, when you come in, to go to a desk and they ask you who you are and what insurance do you have, and then you're in the waiting room. And by the way, it's called a waiting room for some reason, and that's because you wait and you wait and you wait. You can schedule around work, childcare, or other medical appointments. It's convenient. You complete it at home. No concern about masks, social distance, impact on your health. Ease of use. You've been doing Zooms. This is a Zoom, but please bring your hearing aid. Increased access. And if you read the article by Harvey and Christina, evidence shows that outcomes using telemedicine is equivalent to face-to-face. So if somehow you think they're going to lose something because you're doing this remotely, evidence doesn't support that. Additional factors to consider. You want to tell patients, we're not open 24 hours a day. We can schedule these in half-hour increments, Monday through Friday, 8 to 4. Again, now we have to determine if the patient is residing in Missouri. Hopefully this will stop by the 2023. I'll show you in a little bit. We counsel them on the advantages and disadvantages of remote fine-tuning and remote care. And again, this was all developed. We had to put this all together because we decided to do this. And then again, we had to order cameras and microphones because we were using desktops and we were not using a laptop. And then in our packet, we remind the patient when we do this, please be sure you have a secure and stable Wi-Fi. If you don't have Wi-Fi and you have a phone, make sure you have a unlimited data because it can suck up a lot of data. Do you have a smartphone? That probably should be on top. Do you have a smartphone? It's important that you be in a well-lit environment like I am here. This would be a perfect spot to do remote fine-tuning. And it's quiet. There's nobody here except for my cat, and my cat is sleeping in a sink here to the right. It's nice and quiet. There's the microphone there's the camera we bought that has a built-in microphone that we put on top of the monitor of each of our fitting booths. We offer this with Widex, Resound, Starkey, and Phonak. I did not, but Catherine Colopy and our extern put together beautiful step-by-step instructions on all 4 of these with screenshots and tested it out on each other to make sure it works with their smartphone. And then I'll show you in a moment where we put this. And then we also develop patient counseling handouts for each one of the 4 manufacturers because what they offer is different. And we wanted to share that. So on my desktop, my face is here and so is Bob's. But if you look all the way to the right, you can see the size of each one of those files. These are the step-by-step procedures in a PowerPoint presentation, or they get printed out on how to use remote fine-tuning in Phonak, Resound, Starkey, and Widex. Again, each one of these were created by Catherine and our extern, and they are fantastic. So it's a kind of a quick guide, and the hope is, as you use it more and more, you'll need less to go back to this. And even better than that, we hire somebody and they do this full time. And then on the next page, these are the handouts. These are Word documents explaining Starkey, Widex, Phonak, and Resound that we give to the patient at the time of our visit. And then each handout says the following: what is remote care? And there's blurbs, each one of these headings. What is remote care and what is remote fine-tuning? How does it benefit me? What are the advantages? What are the limitations? What do I have to do? What's the next step? How do I schedule? What's the next step? What do I need to do this? And again, this is manufacturer specific. And what is the charge? And this is patient specific, depending upon, is it bundled or unbundled? It could be no charge, as I mentioned before. We offered an annual package of 3 appointments using the charge per hour discussed in part 1, or in our menu of services, pay as you use, based upon an unbundling model that I talked about in the first visit. And then we provide them with the manufacturer brochure for their hearing aid. So this is what we give them if it's a Starkey hearing aid that we have dispensed. And again, these have changed over time. This is the Widex that we give them, and there's verbiage on the inside on what it can and what it cannot do. This is Phonak that we give them, and this is Resound. And then in some cases, we took the Resound instructions to the patient. We didn't think it was sufficient. And on the left side, this is what we gave the patient. And on the right side, that's what they got when they looked in that Resound brochure. So we looked at that, and we do it on all of them. Can a patient reasonably do what they have to do by looking at that right side, i.e., the manufacturer brochure? Oftentimes not. So we went into greater detail, step by step, how the patient accesses the remote care. That's another example. So we created the form. You got to have forms that was approved by the general counsel and signed by the patient. States that the service is self-pay when appropriate. They can select an annual, or they do pay-as-you-go, and it's in the sheet. They're informed that the service is not covered by Medicare or a third-party payer. It's offered between 8 and 4, and he or she must be in Missouri when we do this, and they sign this, and it goes into the patient's electronic medical record. The bottom is the challenge: OTC and direct-to-consumer. I believe by the 3 presentations, because I believe that way, it's a 3-pronged approach. First, you got to think about converting from a bundled to an unbundled approach. That's what I talked about in part 1. I think, as I described in part 1, you really need to offer both and let the patient decide which way they want to go. Number 2, you got to think about patient comes to you. Why would you send them someplace else? Keep them in-house. Integrate OTC type devices in your clinic. When I did this back 2 years ago, it was a entry-level hearing aid, and that was it. If I were to do it now, and they were in stock so we could dispense it rapidly, I would order for the 3 clinics a multitude of different types of OTC that was based upon the literature to provide quality care. As an example, I don't know if you can see it, but this recently came out in the New York Times by a young lady by the name of Lauren Draggett. It came out October 26th, 2022, and it goes and it basically does what are the best direct-to-consumer, what are the best PSAPs, what is a PSAP, what is a direct-to-consumer, and more things like this are going to be coming out to kind of guide you that if you're going to introduce an OTC device in your clinic, you want it to represent your quality. You don't want to put in your clinic a piece of garbage. That's my Eastern dialect, garbage. You want to put something that represents the quality of your clinic. I'll give you another example. If you go to YouTube, and also it's in the literature, and you look up, how do I program an iPod 2 as a hearing aid? I did that. I have iPod 2s, and I went to YouTube, and I programmed my AirPod 2 as a hearing aid. Pretty darn good. And the data from Resound, from NAL said it's about as good as a hearing aid in the tests that they ran. And that's also available online. And then I went one step further, because the audio coming out of my TV, not so good. And rather than buy a streamer, I went out for $78 and I purchased, because my Sony TV, which is as big as my house, doesn't have Bluetooth. My silly little iPhone got Bluetooth. My AirPod 2 has Bluetooth. This big TV doesn't have Bluetooth. Did a little research. I found a device that is an adapter for a TV. It goes into the optical output at the back of my TV, and it sends out a Bluetooth signal. And I paired my AirPod 2 to this adapter and my Bose headset to this adapter. And the quality of the sound for $78 is incredible. So I took my AirPod Pro 2, converted it to a hearing aid, and the ability by Bluetooth to stream from my TV. The AirPod cost me what, $180 for a bilateral set? The adapter cost me $78. Took a little time on how to, do it all of it. So if I were in practice and somebody wanted as my service to program their AirPod Pro and set up the adapter to their TV, I can do it. Also, I can do it, but I'm going to charge you for my time, and we can do this remotely. It's possible. So here it is, the last one. Audiologists can't bury their heads in the sand hoping that this is going to disappear. Audiologists need to recognize that some of our past behaviors contributed to this challenge. The challenge is real, and strategies must be developed to prosper. This 3-part series, this is number 3, is my humble attempt to show how to meet that challenge by integrating, unbundling, OTC type devices, remote care, and remote fine-tuning into clinical practices. Thank you for your interest. If you have any questions or need clarification, please do not hesitate to contact me at valentem@witzel.edu. Thank you.
Thanks so much, Mike. Now, as with the other two, I have a fistful of notes, which I plan to implement in my courses that I teach as well, but also just for my own information. And as usual, when Mike Valente speaks, I listen and take copious notes. Thank you so much for your presentation today and the other 2 presentations that are integrated into this discussion. Thank you as the audience for putting up with us for just a little bit longer today than you are used to at this week in hearing. But again, my thanks to Mike for all of his thoughts, energy, and effort that went into his series of discussions here at This Week in Hearing.